Drug pricing is a hot topic. There is bipartisan support for improving drug pricing. And the president and the administration came out in the spring of 2018 with a comprehensive American Patients First drug pricing blueprint. It had many comprehensive interventions to try to address drug pricing. Things like removing the safe harbor restrictions for payers in anti-kickback statute, things like drug pricing transparency, things like manufacturers disclosing prices. One thing that has been proposed is something called the IPI, or the International Pricing Index. It's a three-part system comprising reference pricing to try to reduce foreign freeloading, is the statement to reduce costs in the United States in comparison to other OECD countries. The second part is called the Competitive Acquisition Program, which would bring third-party vendors like pharmacy benefit managers in to manage drug distribution. And then the third is managing reimbursement of physicians. So this cornucopia of drug pricing intervention, I think, is well intended, but practically very challenging. The reference pricing piece is challenging because there are factors in the United States, like pharmacy benefit manager discounts and the 340B program, that drive drug pricing that are unique to the United States, that until corrected will be a challenge for managing drug pricing. The competitive acquisition program is challenging because if you disrupt the entire system of distribution by introducing another third-party vendor, today that's not been helpful at reducing drug pricing when PBMs have done that today. I would be challenged by disrupting the entire system for Medicare beneficiaries moving forward. And the last being physician reimbursement. As a community oncologist, I'll say that the average sales price plus 6% model that was established by the Medicare Modernization Act is already closer to average sales price plus 4.3% after the sequester is taken into account. That when you continue to bring that lower and lower, it may be difficult for community practices to continue to meaningfully treat patients, Medicare beneficiaries in our clinic, and I think that that would be a transition that would rise the total cost of care because of site of service change. What I hope to see is collaborators coming to the table with the administration and with our elected officials to make meaningful change to influence drug prices.